The book in chapter 17 has a really nice review of the digestive system and its function, its neural and hormonal controls. We're going to briefly go over it, but not in great detail. This is information that hopefully you've all had in anatomy and physiology. We're just going to talk about it briefly and then talk about disorders and then what we do with regard to those disorders, or what are our precautions. So the digestive system, also known as the gastrointestinal tract or GI tract, another name for it is the gut. It's basically a long tube that goes from the mouth to the anus, and its primary function is processing ingested food and fluids, breaking them down with enzymes, absorbing the necessary components in the small intestine, and water and electrolytes in the large intestine, and that's its job. So each section of it has a separate part of that job, but all together that's what it has to do. And then it eliminates wastes at the bottom of the tube. So even though there are variations along the tube, the wall of the gut basically has 5 continuous layers. The mucosa, which is made up of epithelial cells, including mucus-producing cells, that's why they call it the mucosa. The submucosa, which is connective tissue, including blood vessels, nerves, lymphatics, and secretory glands. The circular smooth muscle layer, the longitudinal smooth muscle layer, and the serosa, which is the visceral peritoneum. So the peritoneal cavity, the peritoneum is the lining of the digestive, or the abdominal cavity basically. The peritoneal cavity is really the potential space between the parietal and the visceral peritoneum. There's a little bit of serous fluid in the cavity, so structures can move because, the stomach has to move and other things have to move. And there are lots of lymphatic channels to drain excessive fluid from the cavity. So normally this is sealed off from the other compartments of our body. But if pathogens somehow get into there because of, maybe you have a gastric ulcer or a burst diverticula in the large intestine, or some way that things from the outside can get into the peritoneal cavity, because the membrane is throughout the whole area, it can actually facilitate the spread of infection. So sometimes one of the worst things that can happen to you as a complication of surgery is getting peritonitis, which is inflammation of the peritoneum, and it can kill you because you can go septic really easily. So let's hope that never happens. The gastrointestinal tract, the GI tract, is divided into the upper tract and the lower tract. The upper tract is the mouth, esophagus, and stomach, and the lower tract is the small and large intestines. So in the mouth, the oral cavity, it does the initial mechanical and chemical breakdown of food. And the pharynx is involved with swallowing. The esophagus is also involved with swallowing. It's closed except during swallowing. It has the epiglottis and the muscle sphincters at the superior end to avoid having other things go down there. The stomach is an expansible muscular sac, and it acts as a reservoir for food and fluid. It has 3 smooth muscle layers, and it's constantly mixing and churning the food, and it's involved in the initial chemical digestion of proteins with pepsin, and the production of intrinsic factor, which is essential for the absorption of vitamin B12 in the ileum, which is part of the small intestine. It forms chyme, which is the in between food and waste, and that goes into the small intestine. And some small lipid soluble molecules are absorbed in the stomach as well. So the liver, kind of a sidetrack from the digestive system, but it's involved. It's the metabolic factory of the body. It receives blood from the hepatic portal vein, which transports nutrients from the small intestine to the liver. The hepatocytes, which are liver cells, store nutrients, and they play a big role in carbohydrate, protein, and fat metabolism. The production of plasma proteins and clotting factors happens in the liver, and part of the breakdown of old and damaged erythrocytes, that some of it also happens in the spleen, and bile production, and bile is a big part of fat digestion. So the bile that's produced in the liver is then stored in the gallbladder, and then the gallbladder releases it as needed to help digest fats. So it being the metabolic factory of the body, it also helps process a lot of chemicals and drugs. So part of the pharmacology that we talked about last quarter is pharmacologists figure out how medications are eliminated from the body and how fast they're eliminated from the body. So some medications are eliminated through the kidneys, some are eliminated through the liver. So that's an important thing to know, and it has a lot to do with the dosages and how quickly it's eliminated and whether or not you'll get to toxic levels of a drug. So liver's pretty important. When I was a kid, my dad was really big on eating liver, like cow's liver, for dinner, and I always thought it was the grossest thing ever. Knowing now that it's the metabolic factory of the body, I still think it's the grossest thing ever to eat it. But if you love liver, don't let me stop you. But the place in our body that processes chemicals, I just think that's a bad idea to eat that. Okay, forward and upward. The pancreas is also sort of a sidetrack off the main gut. There are exocrine and endocrine parts of the pancreas. So we talked about some of the endocrine parts in the endocrine chapter that secrete insulin and glucagon. The exocrine pancreas is arranged in lobules, and it secretes digestive enzymes and electrolytes. So there are tons of digestive enzymes. I'm not going to read the list to you. You all can read. But they all go into digesting things so then they can be absorbed in the small intestine. The pancreatic duct joins the bile duct and then goes into the duodenum, which is part of the small intestine. The lower GI tract includes the small intestine, which is made up of the duodenum, the jejunum, and the ileum. Villi are the folds of mucosa, and microvilli are the folds of cell membranes that increase the surface area for absorption. So lots of surface area, lots of absorption. That is the major site for absorption of nutrients. That's why it needs all that surface area. There are also some lymphatic vessels in the small intestine called the lacteals to help the uptake of fluids, and there's some immune function in the small intestine as well. It's a site of production of mucus and all those different enzymes to help break things up, and a couple hormones. The lower gastrointestinal tract it consists of the large intestine. It also has lymphatic tissue that's called Peyer's patches. There's most of the gastrointestinal tract does not have resident normal flora, but the lower gastrointestinal tract does, to help break down certain food materials. And vitamin K is synthesized in the large intestine by bacteria. Vitamin K is a big part of clotting factors. In the lower GI tract, in the large intestine, fluid and electrolytes are reabsorbed for reuse in the body. And it's where solid feces is formed to move that waste out of the system. A lot of waste from protein metabolism get formed into the solid feces, as well as into the liquid waste in the urinary system, which we'll talk about in the next chapter. But the large intestine is a big part of that. So there's a chart in the book talking about the neural or the major digestive enzymes and what they digest and where they come from. So you can see a lot of them come from the pancreas, a few from the salivary glands and the gastric cells, and some from the intestinal mucosa. So all of those go into breaking down different molecules so we can use them for nutrients. I'm not going to quiz you on this, it's just good to know that. So if you have pancreatic dysfunction or small intestine dysfunction or something like that, it's going to affect your digestion, it's going to affect your nutrition and absorption. So in the book they talk about the neural and hormonal controls of the digestive tract. Basically, this table is all we're going to hit on. There are different hormones and different neural controls that affect the digestive tract. So with the neural controls, the parasympathetic system, I like to say it's the rest and digest system. So it increases secretions in peristalsis, helps you with digestion. The sympathetic nervous system is the fight or flight system, and it shuts down secretions, or it decreases them in peristalsis, because if you're running from a tiger, you really don't have time to sit there and digest your food. That's the idea behind that. So we're not going to go into the details of all those things, but just as a little review. So we're going to start right into the common manifestations of digestive system disorders. So we all knew that there would come a point in time when we would have to sit down and talk about vomiting, and here it is. So when you work in a healthcare field, a lot of times you are concerned with the things that are coming out of people's bodies. And when you are talking to nurses, talking about vomit and other things and sputum and whatnot, it's just normal conversation. I have to think about the time I was out to dinner with one of my friends who's a radiology tech, and she was telling me some story from the emergency room. We were in a restaurant. She was telling me some story from the emergency room that involved copious amounts of pus. That's all I remember about the story. This was a few years ago. But everybody in the restaurant is looking at us like, oh my gosh, I can't believe you're talking about pus in the middle of a restaurant. And I had to stop my friend and say, well, I think this is a great and interesting story. Not everybody likes to talk about copious amounts of pus at dinner time, but a lot of times healthcare professionals do. So just like cops have a lot of great stories, healthcare professionals have a lot of stories, and a lot of times they center around these unpleasant bodily excretions. So anorexia, nausea, vomiting, and bulimia can all be signs of digestive disorder or conditions elsewhere in the body. So it's not just digestive disorder that causes these things. It can be a systemic infection, uremia, which is a raised level of blood urea and other nitrogenous waste compounds. Emotional responses can cause these things. Motion sickness, as a landlubber, I can attest to that. When I think about boats, I think about number 3 on the list there. Pressure in the brain from either trauma injury or some other type of brain injury. Overindulgence of food or different types of drugs that can cause those things. And pain can stimulate these as well. So we're going to talk about each individual little thing. Anorexia doesn't refer to the psychological disorder anorexia nervosa. Anorexia just means loss of appetite. So anorexia and vomiting can cause serious complications like dehydration, acidosis, and malnutrition. Anorexia, or loss of appetite, often precedes nausea and vomiting. So nausea is a subjective feeling. It's not something you can measure or see in another person. It's not a sign, but it's a subjective feeling. Sometimes it's stimulated by distension, irritation, and inflammation of the digestive tract, but it can also be stimulated by smells, visual images, pain, and chemical toxins or drugs. So nausea is definitely caused by a lot of different things, not just irritation of the digestive tract. Vomiting, another word for vomiting is emesis. We have a vomiting center that's located in the medulla, which is in the brainstem. It coordinates the activities involved in vomiting. And really the thing that has to be coordinated is protecting the airway so you don't aspirate whatever is being forcefully expelled from your stomach. Sometimes what's being expelled includes bile from the intestine. So we have to have these neural coordinations to keep from the emesis getting in our airway and aspirating that. So bulimia is an eating disorder that involves vomiting. Sometimes it's, and we'll talk about this a little bit in the mental health chapter, sometimes it's a binge and purge type thing where people will eat a lot and then intentionally vomit to get rid of it. It can cause damage to the structure of the GI tract caused by recurrent vomiting. So it can damage the oral mucosa, the teeth, and the esophagus. So the vomiting center is activated, the vomiting center in the medulla is activated by distension or irritation in the digestive tract and possibly from stimuli from various parts of the brain, like unpleasant sights, smells, or ischemia in the brain. So some brain injuries can cause vomiting. Pain or stress can activate the vomiting center. The vestibular apparatus of the inner ear, that's your motion sickness. Increased intracranial pressure. So sometimes head injuries, closed head injuries can cause sudden projectile vomiting without previous nausea. Stimulation of the chemoreceptor trigger zone by drugs, toxins, or chemicals can also activate vomiting. So the vomiting reflex, the whole point of it is to forcibly eject something that is not supposed to be in your body. However, sometimes it's pathogens or some, things that have gotten in there and you can't get rid of them quickly by vomiting, and it can lead to dehydration. So there are reasons why we have it, but it can cause problems as well. So there are different ways, because we're healthcare professionals, we like to talk about not just vomit, but the qualities of vomit. So the presence of blood or hematemesis can be described in different ways. There's coffee ground emesis, which is brown granular material, which basically it's hemoglobin has been broken up by hydrochloric acid in your stomach and then vomited up. It looks like coffee grounds, that's why they call it that. A hemorrhage might cause you to vomit up bright red blood. So there's some place actively bleeding when you're doing that. Yellow or green stain vomit can be because it includes bile from the duodenum. A deeper brown color might indicate content from the lower intestine. Recurrent vomiting of undigested food can indicate a problem with gastric emptying or infection. So the vomit center is activated because of the infection. It's trying to get rid of the pathogen, so it causes you to vomit up undigested food. Diarrhea is excessive frequency of stools, usually loose or watery consistency. It can be acute or chronic. It's frequently paired with nausea and vomiting. What a great little trio there. When you have infection or inflammation, because basically your body is trying to rid itself of that infected pathogen. It may be accompanied by cramping pain. Prolonged diarrhea may lead to dehydration, electrolyte imbalance, acidosis, and malnutrition, just like we talked about in the fluid chapter. So a lot of times when you're getting rid of whatever pathogens are in your body, or you have an irritated digestive tract, it's also getting rid of a lot of electrolytes, fluids, and nutrients. So you don't want it to go on for a long time. Blood can occur in normal stools with diarrhea, with constipation, tumors, or an inflammatory condition. So they'll describe the different blood that you might see in stool. Frank blood is where you have actual red blood that shows up in stools, and it's usually from lesions in the rectum or anal canal. So it didn't have time to get partially digested. It's coming out red. Occult blood occult means hidden, so it's small hidden amounts, and that they're not detectable except with a stool test in the lab. They can be caused by small bleeding ulcers. So a lot of times you have ulcers higher up in the digestive tract. The blood is, the little bit of blood that comes out is getting partially digested and mixed in with your stool. Melena is a dark-colored tarry stool, and it usually results from significant bleeding in the upper digestive tract. So gas usually results from swallowed air, like drinking from a straw, or it can result from bacterial action on food, because carbon dioxide is a byproduct of bacterial metabolism, and the bacteria is digesting the food and it's producing excess gas. It can be caused by different particular foods or by alterations in digestive tract motility. And there are lots of things that can cause that. Excessive gas causes irritation, better known as burping or belching, borborygmus, which is also known as stomach growling, abdominal distension and pain, and flatulence. So gas isn't necessarily a life-threatening thing, but it can be uncomfortable. Constipation is sort of the opposite of diarrhea. It's less frequent bowel movements than normal. A lot of times there's less fluid in it, so you get small, hard stools that are difficult to pass. Constipation, just like diarrhea, can be an acute or a chronic problem. Usually chronically, it can be caused by decreased peristalsis, because there's increased time for the reabsorption of fluid if the bolus stays longer in your intestines. So more fluid gets absorbed, and then you end up with a small, hard stool. Periods of constipation may alter with periods of diarrhea, which, worst of both worlds there. Chronic constipation may cause hemorrhoids and diverticulitis and anal fissures, so it can cause a fair number of problems. So the other thing that you can start to have other problems from chronic constipation, just from the trying to pass these small, hard stools, like increased blood pressure, the rupture of small blood vessels, and you can even have problems with compression fractures, spinal compression fractures in people with osteoporosis. So a lot of times after surgery, the peristalsis of the digestive system is slowed down, and people are on medications that might cause constipation. So that's one of the things they're often looking at in the hospital is, has the digestive system returned to normal? Do you have normal elimination? So weakness of the smooth muscle because of age or illness can cause constipation. Inadequate dietary fiber, inadequate fluid intake. Failure to respond to the defecation reflex. So that reflex is created when the rectum is stretched, and if your body doesn't respond to it, nothing happens. Immobility. There's another one of the bad effects of immobility. It slows down your digestive system and can cause constipation. Neurological disorders can cause it because the bowel, bladder, emptying systems in our body are largely controlled neurologically. Drugs, like opiate drugs, can cause chronic constipation. Some antacids and iron medications, and then obstructions caused by tumors or strictures. So back last quarter we talked about fluid and electrolyte imbalances. Dehydration and hypovolemia, which is decreased blood volume, are common complications of digestive tract disorders because electrolytes are lost in vomiting and diarrhea. Acid-base imbalances, metabolic alkalosis and acidosis can result from prolonged vomiting. And diarrhea causes loss of bicarbonate, which changes your acid-base balance. So a lot of times they can start out as digestive tract disorders and develop into much worse problems like fluid and electrolyte imbalances. And last quarter we talked about the consequences of those, and they can be pretty serious consequences up to and including death. So we're going to talk a little bit about pain because a lot of times there's pain associated with digestive disorders. So we're going to talk about different types of pain. Visceral pain is pain in your organs, basically, in your digestive organs, particularly. A burning sensation could be caused by inflammation and ulceration in the upper digestive tract, like if you had a hiatal hernia or acid reflux disease could cause that burning sensation. A dull aching pain can result of stretching of the liver capsule. So stretching of the liver capsule can be caused by an enlarged liver, or trauma and injury. Cramping or diffuse pain can be caused by inflammation, distension, or stretching of the intestines. And colicky, often severe pain, is caused by recurrent smooth muscle spasms or contractions. And a lot of times it's a response to obstruction or severe inflammation. So visceral pain is something, there are definitely symptoms that need to be paid attention to. Somatic pain is different from visceral pain. Somatic pain receptors are directly linked to spinal nerves. So sometimes you can get abdominal muscle spasms as a result of somatic pain. A lot of times, though, somatic pain is steady and intense and well localized. So it might be like the pain from acute appendicitis is very well localized, like it's right there. That spot is super painful. It can be caused by inflammation of the peritoneum, so it could be caused, and we'll talk about pain referral. It can be rebound tenderness, which is tenderness over an area of inflammation when the pressure is released. So someone's holding their stomach because it hurts, and they let go of it and it hurts more. That's that rebound tenderness. You see that a lot with acute appendicitis. So referred pain is a common phenomenon with visceral causes of pain. Referred pain is when pain is perceived at a site different from the actual origin of the pain, and it results from visceral and somatic nerves converging at one spinal cord level. So the source of the visceral pain is perceived as the same as that of the somatic nerve. It can assist or delay diagnosis depending on the problem. So in the example of appendicitis, it assists diagnosis because it refers pain to a super specific spot. And right away you can say, oh, that's it, that's the appendix. But other referred pain can sometimes delay diagnosis because it appears to be something else. Frequently, gallbladder pains can be referred to the upper or mid-back. Liver pains can be referred to the mid-back. Stomach pains can be referred to the upper back. So that referred pain phenomenon can actually decrease or delay diagnosis. So here's some referred pain patterns from the book. So you can see that cholecystitis or pancreatitis or duodenal cancer, or duodenal ulcer, can refer pain to the area right underneath the ribs. Appendicitis refers to the abdominal area, which is a pretty good pain referral. Cardiac ischemia can refer pain to the left side of the chest, arm, or neck. So that can be dismissed as something else. And you can see the patterns for some of the other areas. So sometimes pain isn't always coming from where it seems to come. So malnutrition It can be limited to a specific nutrient, like when we talked about pernicious anemia, that is a B12 deficiency, or it can be a general malnutrition. So causes of limited malnutrition, like the B12 deficiency or an iron deficiency, are usually caused by a specific problem. Causes of generalized malnutrition can be chronic anorexia, vomiting, diarrhea, or chronic inflammatory bowel disorders. Cancer treatment can cause generalized malnutrition because of malabsorption, wasting syndromes, and lack of available nutrients. So just not having enough of the right things to eat can cause generalized malnutrition. So the basic diagnostic tests are used for the digestive system include radiography. Sometimes with contrast medium, they'll have you drink barium, and then they see how that goes through your digestive system. Ultrasounds may show unusual masses. CT scans, MRIs. CT and MRI might use injected radioactive tracers. A lot of times for liver and pancreatic abnormalities, they will use the radioactive tracers for CT and MRI because they want to see the blood flow through the area. They want to see or the hormone flow through the area. Fiber optic endoscopy is used in the upper GI tract, and basically they put the scope down your throat and they look and see what's going on. They can do a biopsy during endoscopy procedures. Sometimes people have strictures in the esophagus, and the endoscopy is both the diagnosis and the cure. By sticking the endoscope in their esophagus, it actually opens up the stricture. Depending on what's causing it, though, it might not solve the problem. Sigmoidoscopy and colonoscopy, the scope goes up the other way through your rectum. It's done as a basic health screening, and biopsy and removal of polyps can be done at the same time. So it's a basic screening for cancer and digestive health. A lot of digestive system cancers don't have symptoms until very late in the game, until they start restricting something, and so it's a good idea to be on top of preventative tests to test for digestive system cancers. Laboratory analysis of stool specimens can check for infection, parasites, and the eggs of parasites, bleeding, tumors, and malabsorption syndromes. Blood tests, including liver function, pancreatic function, and cancer markers, are often done to figure out. So there's some cancer markers for colon cancer that can be tested for, as well as other digestive system cancers. The common therapies and prevention of digestive problems are dietary modifications. A good example is a gluten-free diet in people that have celiac disease, and we'll talk a little bit about celiac disease. That's a preventative dietary modification. They prevent problems by not eating that aggravating nutrient. Reduced intake of alcohol and coffee, because they can both have detrimental effects in your digestive system, and increased fiber and fluid intake. Stress reduction techniques can be common therapies for digestive disorders because stress impairs immune function and tissue healing. And then there's a variety of drugs that are used for different disorders. So there's the table from the book with a lot of different classes of drugs that are used in digestive disorders, and it talks about examples of them and their actions. We're not going to go into detail on those, but just being aware of them and knowing that lots of different things are used to treat digestive disorders. For PT guidelines, patients with GI dysfunction can have increased fatigue levels as a result of poor nutritional status. So you have to consider their fatigue level when you're planning your treatment, and when the PT is setting goals, they have to consider how much the patient can do. A lot of times in the acute care setting, one of the things that we're trying to assess when we're doing treatment with them is how much can this person tolerate. If they can not even tolerate half an hour of activity, then they're probably not going to be able to increase their activity level. A lot of times in the Inpatient setting, you're going to be consulting with a nutritionist to gauge appropriate activity prescription and adjust the patient's caloric intake accordingly. Particularly in patients with chronic liver disease, it's difficult to improve the patient's strength or endurance if they have insufficient caloric intake for the energy requirements of exercise. So it's pretty important that we coordinate with the rest of the healthcare team on that. Reviewing the patient's laboratory values, again, it's important for determining the treatment parameters. If they have different inflammatory, infective, or bleeding disorders in the digestive system, that might mean they have a low hematocrit and they're not going to have very much energy, so that's going to affect your PT treatment session. So patients with GI dysfunction also might have certain positioning precautions. Dysphagia, which we'll talk about, is difficulty swallowing, and it can be exacerbated if they're lying down. It also might lead to aspiration pneumonia. So you want to position them correctly. Portal hypertension can be exacerbated in the supine position because of gravitational effects on venous flow. If the patient has esophageal varices from portal hypertension, then the risk of the rupture of those varices can be increased in a supine position as well. So you also want to avoid maneuvers that create the Valsalva effect, like coughing, because it increases intra-abdominal pressure as well as increasing intrathoracic pressure. So a lot of times we might be instructing the patient, instead of coughing, to practice huffing. So cough training can be part of PT treatment a lot of times, teaching the people to cough correctly or to brace their cough with a pillow. A lot of times using pain management techniques from the PT realm are beneficial to patients who have rheumatic disorders or arthritis and GI dysfunction, because a lot of times rheumatic disorders are treated with NSAIDs, but you can't use them if you have GI dysfunction. So patients who are relying on those for pain and then developed a GI problem might be limited in their functional mobility. So we can help work on that and work on pain management techniques that don't involve medications. Patients that have ascites, which is the buildup of fluid in the abdominal cavity, or large abdominal incisions, are at risk for pulmonary complications. So it also creates restrictions in ventilation because you have that swelling in the abdominal cavity, and they hinder cough effectiveness and functional mobility. So a lot of times we're working on people on effective ways to clear their airway and positioning.